All right, and I think at this point we'll go ahead and get started. And I just want to say again, thanks to Kath and to everyone on this group for all of the important work and helping standardize patient-reported outcomes, which is something that's going to be really incredible. And as a person living with diabetes, I really appreciate this work. And as a member of Children with Diabetes, we're really happy to be a part of everything.
Great, thank you so much, Marissa. I just have literally a couple of slides just to share, and then we're going to jump straight into Dave and to Martia with their presentations. There is going to be a lot of time at the end for questions. We will take as many questions as we possibly can, if not all, and I'm happy to stay later to keep answering questions if we don't get to them all. So please do put your questions in, like Marissa says. So for anybody that doesn't know me, I am Catherine Barnard-Kelly. I am a health psychologist from the UK, and I have been asked to chair this initiative to develop consensus statements on standardizing patient-reported outcomes in diabetes for adults and for children with diabetes. So ultimately there will be two documents, one that says for adults and one for children. As we have all known for a very long time, that the patient-reported outcomes, the lived experience, the psychosocial aspects of living with diabetes are crucially important. And we have known that the biological, the physical, the psychological, and the social are equally important. And go back as far as 1948, when the World Health Organization defined health as a state of complete physical, mental, and social well-being. And what we have done over the last 10, 20 years is we've got really good at developing rigorous, standardized questionnaires and measures for the psychosocial aspects of diabetes. And that was demonstrated in 2020 when the FDA qualified the first ever PRO for use specifically in diabetes around closed loop systems. But parity of esteem between standardized, rigorous assessment of physical health and mental health is absolutely crucial. And it is possible. This is not a dream. This is something that is entirely possible. And what we are aiming to do here is to provide some clarity around patient-reported outcomes, their scientific underpinning, and the mechanism of action. So what that will do is it will help regulatory bodies, research funders, and other key stakeholders to really rigorously, consistently assess psychosocial outcomes alongside physical health outcomes. And it's long overdue. So the aim is 2 consensus statements, one for children and one for adults with type 1 or type 2 diabetes. Both types of diabetes are covered. This is the structure. We have the different sections that look at domains and different aspects that are important within this consensus statement. This is the proposed structure. It is open to debate and agreement. Professor Snoek and Dr. Martia Witt, who are on the call today, are leading on the mapping exercise, and they will explain that in a lot more detail. And Professor David Marrero will be leading with myself on the introduction and the conclusions, and he has a brilliant slide deck and some amazing insights into what we're doing and why it's important. All sections will look at importance, underpinning science, and mechanism of action. And these are our partners and endorsements. So we are endorsed by the AASD to conduct this work. As you can see here, a huge list and a growing list of partners that we are working with. We are reaching out to the IDF and the World Health Organization. And we're very excited, actually, and very privileged that so many institutions have reached out to work with us and to help us to really develop this consensus. So I'm going to stop there. And I'm going to pass you on to Dave, who has got far more important things to say than I have. So thank you very much, Dave. Over to you.
Okay. Good morning, everybody. Some context here before I put up my slides. I'm the past president of healthcare and education for the American Diabetes Association in 2015. I'm also a behavioral scientist and a person who lives with diabetes. Because of these weird qualifications, the ADA was approached about 6 years ago and asked by a Confederation of Industry Representatives, what was the best measure to measure health-related quality of life relevant to diabetes, because they now wanted to include it as part of their approval process when they went to the FDA. They kind of realized one day that the impact of drugs and devices on people extends beyond clinical parameters and had a lot to do with mental and social and family issues. Well, I had to counter them fairly quickly, said, there's not a single measure here. There's not like one instrument. This is it. It defines the field. In fact, you're now talking about what we call patient-reported outcomes. You need to think about this in a broader framework. This gave rise to a conference that was hosted by the FDA and the ADA to look at this issue and to wrestle with it. And I was asked to make this presentation, so I'm going to share that with you today. Okay. Are we good? All right. PROs in diabetes, what are we talking about? This was an issue. It became very clear to me that, at least at the industry level, they weren't sure exactly what they really wanted. They knew that there was a psychosocial element, but they didn't know exactly how to frame it. And we counted that there's a wide range of factors that form the perspectives of people with diabetes. It could deal with perceived health. It could deal with functional status. It can deal with treatment satisfaction. It can deal with diabetes distress and impact, diabetes empowerment, a bunch of things, mental health capacity, but clearly quality of life. And as all of us that live with this disease and all of us that have helped treat it and respond to it as academicians, we know that the impact of diabetes is broad and wide, but it clearly touches the quality of life. So we presented what are the issues that we need to measure in all PROs. So the questions became, what exactly are PROs? How do we measure it? How should we use it? What's the utility of this type of assessment? Do we use it clinically? Do we use it in terms of drug approval? Do we use it for patient satisfaction issues? Do we use it for triaging? A bunch of issues surround that. And what do we need to know moving forward? So clearly, diabetes is associated with both short and long-term consequences that can significantly impact health and emotional well-being. No surprise there. And we know that regimen requirements include changes in diet, exercise, taking medications regularly, monitoring blood glucose multiple times a day, are now continuous glucose monitors. That wasn't really prevalent when I made this presentation. There's episodes of and fear of hypoglycemia. There's medication side effects. There's living in fear of long-term consequences. There's social dynamics and relationship issues. There's quite a few factors that are really involved with the treatment of diabetes, both type 1 and type 2. In addition to the actual development of diabetes-related complications, diabetes may lead to reduced quality, health-related quality of life. This is an observation that had been made, but not as broadly as I would argue it needs to be. So what do we know? What do we know about this? What do we know about the specific elements of diabetes and what's going on? So when we talk about health-related quality of life, we're referring to personal and emotional well-being and function of diabetes and its treatment. So individuals that with diabetes report reduced health quality of life compared with age-masked persons without diabetes. This is a frequent observation that when you're trying to measure quality of life, and particularly as it relates to personal views of health, people with diabetes tend to score lower on this. We also know that health-related quality of life decreases with disease progression and the onset of different complications associated with diabetes. As all of you know, diabetes is a progressive disease. It's a slow, ever-changing disease, and many of the complications that develop over time have great impact on people's functional status and well-being. And we know that there are different experiences of health quality of life for people at different points in their life that are impacted by their type of diabetes and the length of time they've had diabetes. A person who's newly diagnosed may have one set of issues. I've had diabetes 45 years. Trust me, I have a different set of issues than I did when I first developed the disease. Okay. Oops. Well, let's just, there we go. Okay. So how can we measure health-related quality of life, and what were the type of instruments that were available at the time of this presentation? There are clearly diabetes-specific instruments for persons, both children and adults, with both type 1 and type 2 diabetes. There have been efforts to develop very specific instruments that deal specifically with this disease state. We also know that there are generic instruments that measure components that impact health-related quality of life, but are not specific to diabetes. And there are clearly different components to assessing quality of life, including the impact on physical functioning and limitations, cognitive and emotional status, social relationships, fear of the future, and job or school, and possibly spiritual aspects. There's several dimensions to this. So this decision of specific versus generic reflects the complexity of assessing health-related quality of life, as well as the lack of well-validated instruments across the lifespan appropriate to assess various domains of psychosocial impact. This is an issue as this group progresses, I think we're going to have to wrestle with a little bit. When we look at diabetes-specific instruments, there's a vast array of questionnaires that's been used to measure health-related quality of life in diabetes patients, contributing to the difficulty of selecting instruments for future research. So a lot of this has to do with context in my mind. We have to decide what it is we're trying to show and what's the application of that information to some other aspect. We need to look at that because there are a wide array that have different focuses and orientations to different patient-reported outcomes, which are outcomes that you can only get from the patient and not necessarily from any clinical assessment or review of the chart. We know that there are multiple diabetes-specific measures that are available to assess domains affected by the disease, and these include symptoms, worries about diabetes in the future, self-care capacity, locus of control, functional ability, social support, and sexual functioning. We have to ask about the responsiveness to clinical change, because an interesting phenomenon is that so much of the research validating instruments has been cross-sectional in nature, but little is known about responsiveness of many of the health-related quality of life measures to clinical change and treatment effects. It is clear that health-related quality of life results are influenced by multiple patient and disease factors, particularly age, gender, and the presence and severity of disease complications and comorbid conditions. And these things change over time. So clearly, patient-reported outcomes, as they feed into a measure and assessment of quality of life, can be modified or maybe have to be changed to reflect the different situations in which we find the target audience that we're trying to assess. So I was asked to discuss design and selection of instruments, and this was a very complicated topic because the influencing factors should be considered in the design analysis for patients. You have to really see the context and the patient's situation and status before you can really decide what are we going to measure and what instruments are available to help us do it that already exist. We know that researchers selecting a diabetes-specific quality of life measure should also carefully consider the conceptual underpinnings of the available instruments, as there is little uniformity in the definition and conceptualization of health-related quality of life. This is a conundrum. So when you think about design, it's first important to remember that health-related quality of life is not a unitary construct. It encompasses both positive and negative aspects of living with diabetes in terms of social or interpersonal interactions, personal experiences, mood, behavior, management demands in the workplace or at school, and impact of physical functioning and well-being amongst other domains of everyday life. I want to underscore the importance of the positive and negative. There tends to be an orientation in assessing quality of life to look at sort of the negative impact, but in fact, it's important to look at the other side of that equation because some things actually promote quality of life, whereas other things detract from it. We know that disease-specific measures of health-related quality of life may not be related to generic measures of quality of life domains. Moreover, different quality of life domains may be unrelated to each other, which is an important consideration in selecting instruments. We know that both global and specific quality of life domain measures often are unrelated to behavioral aspects of self-management or a measure of control, which is currently still used, the A1C. We know that treatment may have excellent therapeutic efficacy, but not result in improvements in quality of life or even have a negative impact due to treatment burden. Similarly, a therapeutic approach can result in dramatic changes in health-related quality of life over time without corresponding changes in disease, treatment, or functional status. And oftentimes, this causes a conflict between patient and provider as they try to discuss therapeutic choices, because obviously providers tend to always focus, not always, but they mostly focus on the clinical outcome. They want to see the numbers improve, the numbers get better, and there's good reason for that. Clearly, we know that improved glycemic control reduces the onset of many complications. At the same time, they oftentimes present complications, burdens, and things that contribute to diabetes distress, which we know can have very serious consequences, and in many cases almost looks like depression because of the intensity of the experience. So we have to consider this as we think about what domains are important and how we assess them. So here's a few suggestions that I made at that time. First, you need to consider the primary outcome of the intervention or program and clearly identify the very specific primary goal. Again, it started with a request for a single instrument to measure all aspects of health-related quality of life in diabetes as it related to the impact of new treatments and new technologies. And there's simply not one thing that can do that. But if I knew exactly what they're trying to show, I have a better shot at narrowing down the choices. We need to consider what effect that the goals, if achieved, will have on the participant. Are they positive or are they negative? Because it may be important to measure both of those things at the same time. And we need to distinguish between patient-reported outcomes in general and quality of life specifically. Treatment satisfaction, mental health, physical symptoms, self-efficacy, physical impairment or functional deficit, these may be important, but they're not quality of life. They contribute to it, but we don't necessarily measure these when we're trying to figure out how to measure quality of life. We know that we need to avoid using solely composites of component measures. Doing so, pulling pieces out of one instrument and pieces out of another, risks reducing the chances of detecting specific changes that the instrument was designed to illuminate. And we need to consider the impact of an intervention on the quality of life of other close family members and caregivers, as well as the targeted patient. People with diabetes live within the context of their families and their communities. And it's very difficult, if not impossible, to separate the influence that these things have on the patient's perception of their well-being, their quality of life, and several other domains and dimensions that contribute to what we are calling patient-reported outcomes. This will provide a broader picture of the impact of the intervention and allow for a fuller documentation of changes in quality of life. We also need to consider the timing of assessment. Changes in quality of life do not necessarily follow the same trajectory as changes in behavior or A1C. And I can tell you, as a person that's had multiple changes in my history of therapy and technology, that one thing comes in and makes a big difference and another thing disappears and it makes a big difference. There's a lot of changes that are chronologically oriented to some extent. Cross-sectional things are difficult in trying to assess quality of life in people with diabetes. And oftentimes, quality of life will change after changes in other variables or even well before. So if we're trying to make attributions about the impact, let's say, of an intervention, we need to think about the contextual variables and the timing of it and what leads to what and what follows from what. So the recommendations I made at this presentation for future research is that we need to increase the diversity of samples used to develop and evaluate existing and new measures in terms of race, ethnicity, age, and gender. Oftentimes, the instruments do not consider these variables as robustly as I think is appropriate, particularly when we think about race and ethnicity. I'm working in the American Southwest. There is a ton of people here that come from the border, from Mexico. Their culture is different. Their health understandings are different. Their experiences are different, but we don't have instruments that really adequately measure and account for these variations. We need to examine the causal relationship between diabetes and self-management and quality of life using longitudinal designs. We really need to see what happens when we put somebody on a projection that takes them through time and space with variability in their physical and emotional and social status. We need to increase emphasis on the positive aspects of successful chronic illness self-management, because I guarantee you there are positive outcomes that are associated with living with diabetes. And we need to use health-related quality of life measures to inform empowering relationships between physicians and patients. I'm a personal believer in that assessing patient-reported outcomes in a structured way can contribute to learning what happens with my doctor and how this gets expressed. I did a study a few years ago where I used the distress measure. I used a distress measure, gave it to patients in a waiting room, scored it, and then sent it in with the patient to see their doctor. Their A1Cs fell by over 1%. And the reason for that was because they had never talked with their doctor about some of the issues that the instrument illuminated. The doctor said, I just didn't know that was an issue, and it just doesn't come up. So in conclusion, with more accurate assessment of tools that will enable us to better understand the impact of treatments and compare between therapies, patient-reported outcomes and health-reported quality of life, health-specific reported quality of life, can eventually become part of the clinical decision-making process and improve patient care. And this is what I hope is going to be an outcome of the work of this group. So with that, I thank you. And I don't know if we're taking questions or not, but happy to answer them.
Yeah, very happy to take questions. Please put the questions in the chat. We'll answer them as we're going along, and we can present them to you now. So if anybody has any specific questions for Dave now, please type it in the chat quickly, and we'll make sure that they're asked. That was a really, really insightful, really helpful presentation. Thanks so much, Dave. I appreciate it. And yeah, absolutely, very much hoping that we'll be able to achieve that with this initiative. We have a question. Are there specific tools that you identify for accuracy as per your conclusion slide?
No, I hate to point to a specific tool because, again, to me, it has to do with context. There are very good assessments for depression, for example. The ones that are probably the best are structured clinical interviews that take a long time, they're difficult, and not necessarily appropriate for different age ranges. So, depending on how you want to assess depression as an example of a patient-reported outcome that is, germane to diabetes, it really depends on what the patient cohort you're studying looks like. So I could make an argument for pen and paper measures. The PHQ is not a bad instrument for an initial assessment, but you can make the argument it needs additional verification down the road. And most other things are like that. Same thing with diabetes distress. Some things are very appropriate, other things are missing. So the accuracy and specificity depends on who you apply it to.
Yeah, that's a really good point. Thank you. If any more questions come up, they will be in the Q&A and we'll answer them as we go. I'd like now to go to Martia, please, and invite you to open your presentation deck. I'm really excited to hear more about the mapping exercise, because this is going to be fundamental to what we are able to deliver in terms of our consensus. So thank you very, very much, Martia. I appreciate it.
I have to unmute myself, sorry. Thanks, Dave, for your interesting presentation. And with the mapping exercise, we actually take a more of a step back, looking at which person-reported outcomes are of importance when looking at research in people with type 1 or type 2 diabetes. And Frank and I were asked to execute this mapping exercise, and I will tell a bit more about our thoughts on how to do this, and love to hear your input and thoughts on that as well. And I think that this is in line with what Dave just showed, is that when we talk about person-reported outcomes, actually we are talking about the broad concept of quality of life, with different concepts contributing to this concept. So looking at the physical, cognitive, emotional, behavioral, and social functioning. And also specifically focusing not only on the, for example, the psychological distress or the health limitations, but also the positive well-being and the positive aspects and self-efficacy next to the problems. So what do we envision the goal for the mapping exercise to be? To provide an overview of person-reported outcomes domains currently captured in diabetes research, and identify potential gaps. So we want to identify recent or current international initiatives regarding PRO standardization in also looking at examples outside of diabetes research that may be helpful in shaping the current projects. So, for example, looking at examples in heart failure or the ERTC initiative in cancer research. So we will start off with reviewing recent or current PRO standardization initiative around the globe, looking at what do current diabetes guidelines, position, and consensus statements on PROs in diabetes tell us. Do they focus on research, and how does that, which domains are talked about, etc. Do a review on PROs in diabetes research, so systematics reviews, narrative and scoping reviews, and look at randomized controlled trials published in the last 5 years, which domains within the person-reported outcomes are captured as a primary or secondary outcome. So for the review of literature, we of course will look at the different databases, and these are our first thoughts about the search terms. So looking at a PRO, of course, health-related quality of life, treatment satisfaction, and a whole bunch of other search terms that will need to be included. And like I just said, looking at either primary or secondary endpoints in randomized controlled trials, evaluating the impact of, first of all, diabetes medication, device, and technology. And perhaps also to pose this as a question to you all, looking at lifestyle and or psychosocial interventions, service, quality of diabetes care research, as this all has a broadens the perspectives, but also the goal of and the specificity of perhaps of certain person-reported outcomes. So we will look at persons diagnosed with diabetes and or their caregivers, look at proxy measures or proxy domains, not the measures itself. Of course, type 2 and type 1 and type 2 diabetes, and other types of diabetes, are up for discussion, I would think, but might complicate things. And as mentioned, pediatrics as well as adults, including a focus on older persons with diabetes. So if we look at the domains, it will be about the overall life satisfaction, overall quality of life, and then be more specific out of the perceived physical, cognitive, emotional, behavioral, and social functioning. And of course, distinguishing between generic and diabetes-specific domains. And what also in this context is important, the treatment satisfaction and or the burden of treatment, which might contribute to the overall life satisfaction and the overall quality of life. And it might be that we find domains that we have not yet thought of, and that might pop up in the search. So our aim is to start December 1st and have a first report or first results ready in March. and of course are very much open to all of your input on this. So that's it in short for the mapping exercise, and I hope it clarified things a bit more, but open to discussion and input, as I said.
Thank you, Marta. That was really helpful. Any questions at all for Marta? And Frank, do you have anything you would like to add?
I think what obviously will be critical is to think about how the mapping exercise can actually build the foundation for this consensus project, at the same time not obstruct it. I think we can work parallel in the way that thinking about and hearing the voices of the different stakeholders. So we should not sit still until the mapping exercise is there. On the other hand, I think the mapping exercise will, I mean, that's the primary reason for doing it, right? Is to give a clear overview. This is the current status. Here are issues we need to decide on. And here are maybe some examples of initiatives, previous reviews that exactly describe what we are planning to do. And we should really be cautious of all the work that has already been done in the previous years. I think we saw some very nice reviews, initiatives also from ICHOM, other papers that came across. So we need to be, I think, appreciative of the work that's already being done and don't invent new wheels. At the same time, this is the moment, I guess, to look at it from a fresh perspective with the focus on research and see what is needed to come to a consensus. Is it possible? I would think yes. And then, of course, what next steps would come once we've agreed on the domains. I think both the first and the second presentation combined nicely capture what we're aiming for, and that is we know what to measure, and secondly, how to do it well.
Yeah, exactly. This is the thing. I think fundamentally, you know, there are some really core aims of this initiative. One is to really add clarity to what are patient-reported outcomes, and why does that matter? Because I think there's so much uncertainty in this space. It makes it difficult when people are trying to identify what and how they're going to measure in their research studies. So I think if we can aid clarity specifically in this field, that would be really helpful. I think secondly, if we are able to provide some understanding of the science underpinning the core domains and mechanism of action to improve physical health, mental health outcome, again, that will help people to then go to see what measures are available and to select an appropriate measure for their research study. Because as has been said really clearly in the last two presentations, the context will be different for every research study. Marta, I wanted to ask you, there's a question come in, any ideas on commonality of language used by people with diabetes for domains, for example, treatment satisfaction, burden of treatment? Do you want to take that one?
I think this refers to how domains are, yeah, the spoken of, or how it's. I think it depends on what comes out of the how people refer to it in their research or in the domains or in the restatements. But maybe I'm not understanding the question quite well.
So I'm wondering, in terms of commonality of language, because Marissa asked later, actually, I was just typing a response, so I don't need to because I'm going to answer it live, is with various language guidelines advising against terms like patient, would you consider reframing person-centered? Yeah, person-reported outcomes is absolutely fine. Very, very happy to reframe to person-reported outcomes. So yeah, we've answered that one. In terms of ideas of commonality of language used by people with diabetes for domains, treatment satisfaction, burden of treatment, My view is, and Dave and Frank, please do jump in if you have any thoughts. My view is actually that if we are able to describe the domains that we are referring to and the underpinning science and the mechanism of action, actually that will help to add some clarity. I think there will always be different ways of saying the same thing. So I think as long as we are very clear in terms of what exactly it is that we're referring to, and then the underpinning science, then I think we'll be able to address that. Any thoughts, Frank or Dave?
Well, I guess in research, we even speak about participants rather than patients in person. So I think there are different terms that we can use that are appropriate. But I think it's a good point. We need to be sensitive and hear the the people's voice who are living with diabetes and who are participating in research to see what they would prefer. But I guess words like persons, participants are, I would say, neutral enough for everybody to be acceptable.
Yeah, I agree. Dave?
I would agree with that. And I always come back to context. It really depends on what I'm trying to answer, as to how I approach it and the techniques I'm going to use and who I have to talk to and all those kinds of things. To me, it's always about context. And if you think about the utility of this type of research, it's going to filter into industry. It's going to filter into clinical care models. It's going to filter into, at least in the United States, to healthcare organizational frameworks. And so I think that has to be always put into the mix.
Yeah, no, I think you're right. Andrew makes a point, often consensus reports cluster type 2 diabetes and type 1 diabetes, but these can be very different disease states. They are absolutely very different disease states, we agree. Populations and treatment regimens. Will these be discussed separately? It seems that type 1 diabetes is disadvantaged in these documents if clustered. They will absolutely be discussed separately in both the adult and the pediatric consensus statements, and that will be very clear. My view is very much they are very different diseases and they have different etiology and therapy regimens. Any thoughts, guys?
Well, I think that's absolutely correct. And following up on Dave's introduction and stressing the importance of diversity of samples, I think that will come back in our mapping exercise also when it comes to what are the relevant domains. I fully agree with David. This is so context dependent, which would include people's cultural, religious background. So I think that's one of the things we should be really critical of in terms of what is captured and what is not captured, potentially should be captured, given the diversity of the different samples. Of course, we know that in research, unfortunately, many minority groups are not included for various reasons. So that will probably, this problem will probably pop up. So we need to be aware of that. I just wanted to add that. Yeah.
Yeah, absolutely. Neil is asking, in addition to health-related quality of life, will you include mechanisms of action for behavioral interventions, such as increasing self-efficacy, patient activation, readiness to change, etc.? Any thoughts?
Yeah, I think that's an interesting one. How far do you go? And especially for those behavioral interventions and psychosocial interventions, there you have such specific mechanisms or outcomes that might go beyond this consensus statement. So we have to, of course, things like self-efficacy that contribute to self-management behavior is such an important construct. Yeah, so readiness to change, I might think would be specific for a certain intervention or a certain topic, but not part of the person-reported outcome consensus statement.
Yeah, I would agree. So I would say self-efficacy, yes, but I would say patient activation and readiness to change would go beyond the consensus statement, because I'd like to think, and please tell me if I'm wrong, which is entirely possible, I would like to think that patient activation, and I hate the expression patient activation actually, because people, I think people are activated. I think readiness to change is a better expression. I think that they will come out of the domains that we identify in terms of the measures that people are then able to select in order to assess that. But I think self-efficacy, yes, but I'm less sure about the other two. Dave, Frank, any thoughts?
Yeah, it's interesting. I'm listening to this and I'm thinking, just like everybody does, I'm thinking about my own environment here. And we look at aggressively what we call social determinants of health, which is a proxy, if you will, for readiness to change. In other words, it may be capacity to change. Can you even do it? And so in a lot of the work here that you see in the Southwest, where you have large immigration populations and you have immigration status issues, which cause lack of disclosure in the healthcare system. People don't want to tell you that they're not here as documented, residents. It becomes sort of complicated. So there's a part of me that thinks that, what we call social determinants of health are patient-reported outcomes to some extent. You know what I mean? Just a slightly different framing. And it goes back to what Frank said. It really depends on the context, the ethnicity, the mix, and what's going to influence. So if we're going to go all the way back to the question about, do we want to be looking at studies that are going to look for readiness to change? To me, it would be important to initially assess some of what I call social determinants of health, sort of the same term in a way, our patient-reported outcomes. You'll get their perspective. That's going to give me a lot of information about whether I should even bother to approach them with different interventions. You know what I mean? Because the chances of getting them done in some cases are zero. So complex issue. But to me, patient-reported outcomes goes back to the concept that these are things I can only learn from the patient. I can only get from the individual, and there's no other mechanism other than basically asking, are looking at proxies that speak to that are going to help me do that. So that's, I guess, what I think.
Yeah, and if I may add, Dave, I think that within the, let's say, psychosocial research, much of it is theoretical driven and has a specific intervention in place, and therefore choosing certain outcome measures. For the purpose of this consensus, this is probably critical that we define the scope of the consensus. I guess the primary concern that we all have is that we should, as you were explaining, Kath, provide clarity and, if at all possible, standardization in terms of what are the person-reported outcomes that are relevant in medical research, including medication, devices, technology. I think the question is maybe, more service-related research, where let's say a systematic approach is studied against, let's say, a less systematic approach, maybe based on the chronic care model or whatever, that perhaps should be included because it directly relates to, what are the relevant outcomes for people when you improve care more in general terms. I think when we move towards the psychosocial research, it gets a little bit more complicated, but as I said, it's often very specific for the intervention. A second complication of that also is that many of us who are involved in that type of research have very, very strong ideas, convictions, religions, I would say, as to how it should be measured and what should be measured. So maybe we should stay away from that, at least initially, and focus on the medical research.
Yeah, no, I agree. Yeah. Best practices are important, but are we going to include statements for things that realistically can be measured? Meaning not every study or intervention can include structured clinical interviews. So for scalability, are alternatives in the real world going to be included? I think you've actually just answered that, Frank, actually. Anything to add, anybody?
Yeah, I would think that for in general there would be a sort of core set of domains that you would include in every type of research, and there could be specifics depending on the study or the context or things like that. And of course, yeah, we're not going to suggest certain measures, but of course, yeah, it's about what's realistic. Yeah.
Yeah.
But that would be the
And
next
that goes
step,
back to
how
context.
to do it.
Yeah, exactly. Thank you for great presentations and important work. I agree, guys. They were brilliant presentations. A few years back, in Design for Type 1 Diabetes Exchange QI network, through co-production with people with diabetes, we identified a concept PRO of the suck factor. That's great. I know, right? The suck factor. How much does it suck? With improvement goal to reduce or eliminate burdens, time, financial, stigma, burnout, etc. We did not find an existing measure for suck factor, although diabetes distress approximated. We'll be curious if mapping reveals a measure that captures this concept. Come on, Frank and Mattia. Find one.
There is, I mean, this is quite an interesting comment, because we are stuck, of course, with our, let's say, convention that it has to be a questionnaire with, asking questions and then a rating by the respondent. And in the area of, let's say, to what extent a disease sucks, across different diseases, measures have been used using different approaches to capture, let's say, the intrusiveness, the illness intrusiveness, as to use a term that I think is somewhat similar to suckness. So I think that's a good reminder of broadening the scope in terms of staying alert to these different approaches. And I don't think, well, I'm pretty sure that suckness is not a search term in
Never know.
We can find equivalents.
It seems though that if you wanted to go down the path of a suck factor, which to me translates into diabetes distress, to be honest with you, I mean, different term, but I think whatever we focus on has to be able to show change. Yes. In other words, it's one thing just to know it, it's there and that's a factor. And then how you account for that in your designs becomes an issue. But I'm a big fan for PROs of their utility and using them as a metric for the quality of care being received. You know what I mean? So I see PROs as being deficit in the healthcare system here in the United States. They don't really assess it very often. I never have my doctor ask me about personal related stuff, very, very, very rare. It's more about mechanistic elements. And so whatever we come up with, whatever domains we center in on, I think instrumentation should have the capacity to detect change, which what you hope is that you reduce the suckiness, right? Versus increase it. But if you increase it, that's important. And when I talked to industry, which led me to the presentation I made, their whole issue was we realized that we produce treatments, be it medication or technologies, they can in fact add burden. You know what I mean? They can in fact be viewed negatively or will be rejected from their perspective. They're thinking about the profit margin, but they can reject it because nobody wants to take it. And there's reasons for that. And they couldn't figure quite how to assess that. So they use quality of life as an easy catch-all domain for it. But, if we can produce suggestions about domains that has some capacity to detect variability in that response based on whatever you're doing, be it an intervention or a new treatment or something like that, I think that's a good direction to go.
Yeah, I agree. And I think that in some part actually answers Linda's next question, which is how do we address issues related to first understanding the constructs underlying and relevant to some of our more ambiguous but frequently mentioned and possibly very important determinants of quality of life and glycemic outcomes, that kind of that person engagement as a prime example. What do we actually mean when we talk about person engagement? And then when we understand what we mean by person engagement, how do we actually measure that engagement? And this is to your point, Dave, about that kind of status of change. And there has to be a point that you need to be able to assess that. What's different? I mean, it's all very well. I mean, we've kind of always taught that unless you can actually assess something is going to be different, then it very much becomes like, navel gazing, which would be deeply offensive. So I think yeah, there has to be some kind of understanding of change. I don't think it was as well. So will we include PROs for family members and caregivers? Yes.
Oh, yeah.
Yeah,
Yes.
is the answer to that. That was an easy one. Thanks, Neil. And then we've got, what do you think about the concept of discussing PROs with the people with diabetes that we treat in clinic? We are in the process of implementing a system for a yearly routine in our clinic, and it seems like an intervention in itself because things are being discussed that otherwise never are discussed. Dave Marrero, over to you. I know you have thoughts on this.
Well, yeah, I think it's shared decision-making with your provider is crucial for good outcomes. You need to come up with a plan that's going to work, a treatment that you can live with, and that is adequate to achieve the clinical aims that your provider wants to get to. So, yeah, I'm a big fan of front-loading those clinical encounters with information from the patient that would factor into the provider's decision-making process. Because it's very inelegant to me to sit down in a clinical room and have my provider try to figure out all my personal stuff. You know what I mean? Even though it's relevant, it's very relevant, but they don't have the time for that. At least in the United States, they don't. So, that's sort of a problem. And so I'm a big fan of suggesting to people that if you, and this little study I did with the PAID, the problem areas in diabetes, showed that in fact, if I get that information and then provide it to the doctor before the clinical encounter happens, it changes it. So I'm a big fan of PROs as a front-loading element being introduced into clinical care systems, which should be more doable now than it used to be because of patient portals and all that kind of stuff, that you might be able to make some big gains by having that information contribute to the shared decision process.
Yeah, absolutely. Marissa, can you talk about the reason behind deciding not to evaluate the quality usefulness of existing PROs of various constructs? That's my daughter home from nursery. 1 second. Obviously had a good day. Existing PRO measures of various constructs in relation to this process resulting best practice for assessment as part of this effort. Yes, I can absolutely take that one. We have 6,000 words. That's it. So this is definitely going to be subject to a future piece of work, but within the current initiative, this first step, as Frank says, this is about research. It's about understanding the constructs, the domains and their science. It's about clarifying what person-reported outcomes are and why they are important. And it's about explaining the mechanism of action. And I think within the remit of this piece of work, I think that's actually the most that we can achieve. And I think that in itself is going to be a very valuable document as a blueprint to being able to have that standardization of assessment and understanding across all key stakeholders, including regulatory boards, including grant funders, industry, and beyond. So I think providing that clarity and that science and that understanding of mechanism of action to really crystallize the voice of people with diabetes, which is just absolutely crucial, I think is as much as we can achieve in this document. But I know that Frank, as we've spoken about this, and we agree that this piece of work will need to be done, but that will fall out of these initial documents for adults and pediatrics. will be the basis of a further piece of work. But we agree, it's difficult. And I think, Frank, you once said to me, actually, that scientists would rather share each other's toothbrushes than use each other's measures. So finding consensus in which PROs are the best, I think we will all be very old by the time we were able to achieve that. But what I'm hoping is that if we can provide this framework, this blueprint for this standardization around what is it, why it matters, and that in itself will be an achievement, and add clarity to the field. But also the science and the mechanism of action, I think, is really crucial in this first step for this blueprint. But I think there's going to be a huge amount of work that follows these two consensus statements for adults and children, like I say, and that will definitely come next. There's one: could a minimum group of PROs be defined for usual clinical practice? Again, we worked, Frank and I were both on the ICHOM International Consensus of Health Outcome Measures work that was done a couple of years ago. They attempted to do that, and I think it was a very good piece of work. It is beyond the remit of this project, but what we're hoping is that by understanding the constructs and the mechanism of action, that will actually help people to go and choose the best measure for them in the context of why they want to use it. So, but I think a lot of work this is a first step, and it will fall out from that. Leslie, ADC has completed 2 systematic reviews on quality of life type 1 PEDS, pediatrics. We focus on diabetes education specifically, and the research was very limited. Definitely identified a gap. Happy to share both. That would be amazing. If you could share, that would be brilliant. If you want to send them on to me, you've got my email. We correspond obviously frequently. I'm very happy to connect you to Martia and Frank, and I'm sure they'd be very, very grateful for those. And yeah, hugely grateful for your input into this initiative and the support that you've shown so far. And we're very excited to work with you on this. It's yeah, we're very grateful. Thank you. And we've got one more: context, perception all matter. How will you help us group terms, ratings, descriptions that fall under broad PRO domains? Who wants to take that one?
I'm not 100% sure what's being asked.
Yeah, how context, perception all matter. How will you help us group terms, ratings, descriptions that fall under broad PRO domains? I'm not sure what that is either, actually. I'm sorry, Pauline.
Well, I think, well, if I understand the question, is that there are so many perspectives maybe possible on the same domain, and do they actually capture the domain in its full depth, and how will we synthesize it? I think that will be part of the mapping exercise and the discussions among ourselves, of course. If we work empirically, we categorize the different terminology used related to the different domains, etc. And we might come up with at least some linguistic or language issues, like, is this are we talking about the same thing? And we probably have to dig in deeper then to see if it is about the same. So I think the topic is very relevant, particularly because it's about perceptions. So people might word it differently. And we know that if you look at questionnaires, patient-reported outcome measures that claim to measure the same thing, and you look at the item content, they might be quite different actually, which probably comes from the different perspectives that the developers had, or the patients or the persons they consulted. So we are aware of that complexity.
Yeah, no, she said, thank you, that's it. Thank you. Okay, I think we've come to the end of our time, and we've answered all of the questions, which I'm very happy about. I just leaves me to say a huge thank you so much to Frank, to Martia, and to Dave for being involved in this work, and for presenting today and answering the questions. want to say a huge thank you to Marissa and Jeff for hosting the webinar and for being so actively involved as a partner in this initiative. We're very excited as we move forward. We are acutely aware of the many challenges that we face, and we hope that collectively as a group that you guys stay involved, and that we are able to produce something that is really meaningful and useful, so that we can build on that in the future. So a couple of guys in the questions saying thank you. Thank you so much for joining. We're really grateful, and we'll keep you informed for the next one, and we'll have more to share about progress.
Thank you
Thank
for
you,
the
Kath.
opportunity.
Yeah,
Thank
thank you
you.
everyone very much. Just wanted to let you know the recording will be saved, and I'll have Kath send it out. And CWD just wanted to thank everyone for logging on and for those that are taking leadership in this meaningful project. So thank you.